or good afternoon, everyone, depending on where you're joining us from, and welcome to today's webinar. My name is Kalina from Business Review, and I will be your host today. It is our pleasure to have QPS with us today, who will be presenting this webinar titled Continuous Cerebrospinal Fluid Sampling via an Indwelling Spinal Catheter in Clinical Pharmacology Studies. Today's guest speakers are Dr. Isaac Dendaas, PhD, Director of Patient Studies at QPS Netherlands, and Professor Anthony Absalom, MD, PhD, Professor of Anesthesiology, University Medical Center, Groningen, Netherlands. I would like to welcome you to our webinar platform on 24. You will notice that this webinar is browser-based, so if you disconnect for any reason, please just click on the link that you received via email to rejoin the session. In order to ask questions, you can do so via the questions widget at the top right corner of your screen. Just type them into the box and click submit. Towards the end of this session, we will allocate some time to address any questions or thoughts that you may have. Please also use the yellow help widget if you require any assistance. You can move, resize, and maximize any of the windows in front of you to get a better view of the slides. But now, please allow me to welcome Dr. Isaac Dendaas. Over to you.
Thank you. Well, good afternoon, good morning. Well, this webinar is about CSF sampling, continuous CSF sampling via indwelling spinal catheter in clinical pharmacology studies. And yeah, CSF sampling by lumbar puncture LP is often used in clinical practice for diagnostic purposes, most of the time in neurodegenerative disease like Alzheimer, ALS, Parkinson's disease, and also in MS. In drug development, LPs are often used for the investigation of investigational medicinal compounds and can be a valuable tool for the pharmacokinetic and pharmacodynamic assessment of drugs. However, single punctures have limitations because you can only do two up to maximum 3 samples per volunteer or patient, and therefore interval cerebrospinal fluid sampling by indwelling catheterization can be used for better PK and PD evaluation in the CSF compartment. And CSF sampling studies on drug candidates for Alzheimer's disease have been conducted in evaluations of inflammatory markers, neurotransmitter and their metabolites, tau proteins, and of course amyloid precursor protein and beta amyloid fragments. And I'm handing over now to my friend. Oh no, another one. Introduction. So increased complexity in drug research and development is one of the reasons for more and more specialization. Therefore, you need more specialists from different scientific disciplines. So additionally, drug development programs are faced with increasing developmental costs to boost their pipeline of drug candidates. And these include increased demands on the partnership between academia and industrial pharmaceutical research in order to find solutions for measuring biomarkers of complex pathways in vivo. And in this context, CSF sampling is a very important source of information on neurotransmitter, neuropeptides, metabolic substances in clinical research in the area of psychiatry and neurology. Linking these biomarkers with pharmacokinetic data is, of course, a very, very valuable tool by using serial CSF sampling, also known in the literature as continuous CSF sampling, to provide researchers information which will enable them to follow the progress of medicinal intervention in the CNS diseases during different developmental stages of drugs. Tony.
So, good afternoon or good morning to everybody. It's a pleasure to be involved. So I thought I would just talk a little bit about relevant aspects of the anatomy and physiology of the cerebrospinal fluid. So the cerebrospinal fluid is contained in the brain ventricles, the lateral, the third, and the fourth ventricle. You can see them in pink in this diagram, and then in the cranial and spinal subarachnoid spaces. So each account differs, but roughly the total cerebrospinal fluid volume is 150. Obviously, it differs per patient, but on average, 150 milliliters, roughly 25 milliliters in the cerebral ventricles, and 125 in the subarachnoid spaces, about 50 milliliters around the brain, so in the cranial subarachnoid spaces, and 75 milliliters in the spinal spaces. Oops. Next slide. Okay, so the cerebrospinal fluid is manufactured or made in the choroid plexuses. These are in the ventricles, the three that I've mentioned. And maybe some cerebrospinal fluid is also filtered from the capillaries, from the interstitial fluid and epididyma, but that is questionable. On average, around 20 milliliters of cerebrospinal fluid are made per hour. So what you see in the literature, the rate per day is between 16 and 25 milliliters per hour. And that's relevant when you're thinking about how much you might want to take in one sampling. Okay, and then below, this is no need to go into all the details, but how is it made? Some of it is passive filtration of plasma from the choroidal capillaries. And there's also active transport against or with gradients of different molecules. And here, carrier proteins, ion exchange pumps, aquaporins play a role, and carbonic anhydrase also plays a role as it affects the pH. And then certain growth factors and other molecules are actively secreted, and possibly some drugs. Next slide, please. Okay, so I've told you how it's made, how it's secreted, and it's from the arachnoid villi. It's absorbed, it's secreted from the choroid plexuses, and it's absorbed into the arachnoid villi. These are in the cranial space, and in the spinal space, you have these arachnoid villi. And these drain absorbed CSF into the venous system. And what these figures on the right are showing is that the amount of absorption is also dependent on the pressure. So you see this blue, that's representing cerebrospinal fluid, and the choroid plexus is that little frond-like structure. And when the pressure in the cerebrospinal fluid is high, the blue is the vein, and the cerebrospinal fluid, when the pressure is high, that frond, or that structure, that villi, gets bigger, has a bigger surface area, and more cerebrospinal fluid. I'm going to try and show it with the mass. Here is cerebrospinal fluid. Here, that's the villus, and this is a vein. In this case, probably the sagittal sinus. So it's influenced by the pressure. There are a few other sites where the cerebrospinal fluid may be absorbed. And from these, it's thought that it gets absorbed into the lymphatic system. Now, there's 150 milliliters of cerebrospinal fluid. It's made in the, as I mentioned, in the choroid plexuses, and it circulates through the whole system. And how much it circulates depends on many factors. These include the arterial pulse and respiratory waves, which cause pressure waves in the cerebrospinal fluid and help maybe with circulation, posture, jugular venous pressure, and also physical effort can change alter the circulation. And it's just an important point here, aging causes reduced turnover of cerebrospinal fluid, and this can cause an accumulation of metabolites and other molecules in the brain and cerebrospinal fluid. So probably there's less production and therefore less absorption in the elderly. Okay, now We don't need to go into detail on the functions, but an important function is that the cerebrospinal fluid offers hydromechanical protection to the central nervous system. So there's a layer of cerebrospinal fluid around the whole brain, and in a way you could see it that the brain is floating on this layer of cerebrospinal fluid. It's a small buffer, and if you drain too much cerebrospinal fluid and the pressure falls, then the brain can sink with gravity. So if the person's standing, it will sink towards the ground slightly, and this is part of this will cause a headache because there's pressure, traction on sensitive structures like the veins. Okay. Now the constituents of the cerebrospinal fluid, there are some significant differences in solute concentrations compared with the plasma, and also some differences compared with the interstitial fluid. So I've listed some of the differences at the bottom. Some solutes have higher concentrations, other have lower. A notable one, of course, is glucose, which is usually about 2/3 of the plasma glucose concentration, and proteins and albumin also, because albumin doesn't normally cross the blood-brain barrier much, although it does increase the crossing, and the concentrations increase with advancing age. Our constituents are influenced, as you see above, by autonomic innervation, by humoral regulation, different enzymes and membrane transporters, by the acid-base status, and this is important if patients are taking certain drugs. Monoamines, like norepinephrine might affect it, neuropeptides, and drugs, once again. So especially loop diuretics and carbonic anhydrase inhibitors, which alter the acid-base status in the brain. Okay, now I'm not going to go into detail here, but systemically administered drugs, whether they're taken orally or intravenously, they can reach the CSF, and you all know that, and I guess this is why you're attending the seminar today. But anyway, in brief, the passage can be direct via passage across the choroid plexus, or indirect through passage across the blood-brain barrier. It should be remembered that not all drugs, not all molecules cross the blood-brain barrier. Now, talked a little bit about the circulation and of cerebrospinal fluid. Known that there are gradients throughout the cerebrospinal fluid in the concentrations of different molecules. And so here's just a chance for me to show you some data from a study that we've got, or I've got, going in University Medical Center Groningen with a team of mine. We have a biobank of cerebrospinal fluid. We have cerebrospinal fluid stored from 500 patients undergoing surgery under spinal anesthesia. But in a sub-study, we specifically looked at this issue of gradients. And I'm showing you this data because if you're wanting to do a study, you need to think about gradients. And so I'm just going to run you through these graphs. So from each patient in our biobank, but this is from a subgroup of 20, from each of them, we took 5 serial samples of 2 milliliters. So we 5 times we aspirated with a 2 milliliter syringe and saved these aliquots separately. And then we performed a whole bunch of assays. I'm just showing you a little sample here in each sample. So what you can see is that in the first sample, down through to the 5th, the albumin concentration is slowly decreasing. For glucose, it's staying very similar. In fact, it's for a single patient. I haven't connected the dots, but I can tell you that generally there's minimal difference between one fraction and the next. So glucose is very similar. But then, as is well known, this is a metabolite from the monoamine pathway, homovanillic acid, you can see that the concentration increases significantly. And these gradients, they depend on whether the drugs are mostly coming from maybe the brain side or from everywhere where there's contact between the blood-brain barrier and the cerebrospinal fluid. So it all depends on the structure of the molecule of concern and how it gets into the cerebrospinal fluid. So this is worth keeping in mind. All right. Now, some important issues to discuss about cerebrospinal fluid sampling. So a lot of the time we just do a lumbar puncture. So we put a needle from the back through the lumbar vertebrae, through the dura, mater, and arachnoid mater into the cerebrospinal fluid, and we take a sample. And when we put an indwelling catheter in, it's a bit further. So instead of just putting a needle in that space, in this intracecal or subarachnoid space, we end up leaving a catheter there. So whichever we do, there's certain risks that have to be borne in mind. If it's a simple puncture, single puncture and out, these are the risks here. I've mentioned them. There could be local pain and discomfort during, but usually if we use a fine needle and we first inject some local anesthetic, there's almost none. Just the first prick of the needle to inject the local and then it's over. But some people do have longer-term backache. I've never really seen a clear explanation for why, but some do complain of it. Maybe they would have got it anyway. Much more important, but much, much more rare, is neuronal injury. So when we do a lumbar puncture, we do it below the tip of the spinal cord. So usually the spinal cord ends at the first lumbar vertebra. And below that, there's nerves in a sac of cerebrospinal fluid, and we put the needle in there. So if the needle direction is wrong, if it goes somewhere where we don't want it, and the needle, this can be flexible, there's various reasons why, but neuronal injury is possible and can cause functional loss, but luckily it's very rare. I think serious neuronal injury is probably of the order of 1 in 100,000 or so. Now, to get to this subarachnoid space, we have to go through the epidural space, and then, as I say, through the dura and through the arachnoid membrane. So in the epidural space, so the space outside of the dura, we have this fatty tissues, but it's also vascular. So sometimes you can puncture a blood vessel in the epidural space that could cause some bleeding. And similarly, it does sometimes happen that there's subdural bleeding, so a vein is punctured between the dura and the arachnoid mater. And if there's a lot of bleeding and it collects, forms a hematoma, this can compress the nerves and the spinal cord and has, in some cases, caused paraplegia. This is devastating, but luckily also very, very rare. If technique is not fastidious, so really careful, it's possible that puncturing the subarachnoid space can introduce infection. So we're extremely careful with our technique, because if you introduce infection, you can cause a spinal abscess or meningitis, and this can also have very bad consequences. So with careful technique, careful attention to asepsis is very rare. There's another one that's extremely rare, but I sort of will give you the whole horror story here. But adhesive arachnoiditis. So there have been cases, just a handful in the literature over the decades that these spinal punctures have been done, but where there's been slight contamination of a needle with the disinfecting fluid. And this is another reason why the anesthesiologist or whoever's doing the puncture has to be absolutely careful, because some disinfectants, and in fact the commonly used ones, if they get into the epidural space or anywhere near nerves, they can cause a chemical arachnoiditis, and sometimes this can cause a paraplegia or worse. So there's something to avoid. So those are the serious ones, but luckily extremely rare. But much more common is post-dural puncture headache, and we'll talk about it in a minute. but this is a known complication. Happens in about 1% of all cases of patients or volunteers when they have a single shot lumbar puncture. Now, when we leave an indwelling catheter in situ, this can cause all of the above complications, but it increases the risks of infection. So technique is all important, and it can increase the risk of post-dural puncture headache. And we'll drill down onto this in a minute. Now, why do patients or subjects get a post-dural puncture headache? Well, it's caused by leakage of the cerebrospinal fluid. So the dura, which is quite a thick membrane, if there's a hole in it, and sometimes there's more than one, afterwards cerebrospinal fluid leaks out from there. And if a significant amount leaks, this decreases the pressure in the CSF, so there's less volume, so less pressure. And as I mentioned before, this causes sagging or shift of the intracranial contents with traction on pain-sensitive structures. Typically, this happens about 6 hours after a single spinal puncture or 6 to 24 hours after removal of a catheter. And typically it happens not while the person is lying down, but when they mobilize and start to move around, and then there's a column of fluid pressure above the puncture site, which is low in the back, and this causes leakage of the cerebrospinal fluid. Typically, the headache is said to be orthostatic. So when the person sits or stands up, it gets worse. It can be made worse or provoked by sitting up or standing, and it gets relieved by lying flat. Unfortunately, it can be very severe and can be a disabling headache, also sometimes with photophobia, so that the lights hurt the eyes of the volunteer. And this can be alarming because this is also one of the symptoms of meningitis. So headache and photophobia, sometimes even neck stiffness, but these are severe. Okay. Now, how often does it occur? If we simply do a single needle puncture and take fluid out and don't put a catheter or anything, around 1%. Depends on various factors, which I'll go into in a second, but around 1%. But if we place a catheter, the incidence is much, much higher. In the young adult group, 18 to 30, depends on the literature that you read, but it can be up to 80%. So it's very, very common. So young people have slightly less cerebrospinal fluid. Old people with brain atrophy have more. I guess if you just lose a little bit, the brain can sag and this headache happens. Luckily, in elderly patients, and particularly those over 65, post-dural puncture headache is uncommon even after a catheter technique. Now, factors that influence the incidence of headache are the catheter type. So if a catheter is inserted, is it a catheter over needle or a catheter through needle? Catheters, when we do catheter through needle, we use a slightly bigger gauge needle, and the catheter fits inside of that. So that has certain risks. The second is the needle and catheter gauge. So the broader the needle that's used, the broader the hole in the dura, the broader the catheter, the bigger the chance. And finally, when multiple insertion attempts are made, so sometimes with an inexperienced user or simply difficult anatomy or someone with degenerative changes and calcification of membranes and so on, or ligaments, several attempts are made, and sometimes more than one puncture can be made in the dura. And this increases the risk because obviously there's more chance of cerebrospinal fluid to leak. So what do we do when someone gets a post-dural puncture headache? Well, the baseline management is hydration. So maintain fluid intake, give intravenous fluids if necessary. Simple analgesics like paracetamol or acetaminophen for the Americans, and maybe a non-steroidal anti-inflammatory if there's no contraindications. We tend to suggest to the volunteers that they lie in bed, so bed rest, lying flat, so not sitting up. So if they lie flat, it just, there's less leak, and maybe it gives the hole a chance to heal. And caffeine is quite, can be effective in treating the headache as well. I guess it has effects on the tone in the vasculature in the brain, and that can help. Now, some of these posterior puncture headaches can recover spontaneously within a few days, so on their own. But unfortunately, there is a proportion that don't. And if they don't, then they need management. Firstly, because it's a severe headache, it's really nasty for the person having it. But secondly, it can cause subdural hematoma. So essentially, if the cerebrospinal fluid volume is low, the brain is sagging towards the foramen magnum, it's called. This causes traction on veins, and they can tear. And so this can cause a subdural hematoma. So it's also not wise to let someone languish much longer than 2 or 3 days with a posterior puncture headache. And if that happens, we do an epidural blood patch. So this is an invasive procedure that has its own risks. So there's a careful consideration always made. But what we do is we position the person in a way that we would want them to do a lumbar puncture. And then under sterile conditions, we take some of their own blood from a vein. And then with an epidural needle, we find the epidural space roughly near the level that the original puncture was made. And we inject up to 20 milliliters of blood in that space. No one's quite sure why it works, but usually this is very effective. In fact, sometimes the person within 10 seconds feels relief of their headache. So that's an epidural blood patch. So there is something that we can do. Now, I think this is my last slide. Just some technical details. So we've been doing this for some time now. We have a sort of plan that we worked here, and these are some details. So the first is preparation, and in much of life, preparation is half the job. So, of course, you need to select appropriate. Not everyone can cope with the thought of a needle going in their back, even though actually it's not that painful with good analgesia, with local anesthesia, and so on. But then they need a detailed explanation and proper informed consent. So they need to know all that can go wrong, and they need to know how it might be resolved. They need an honest, no holds barred explanation, and they need to consent to that. And then when it's coming up to the time of the puncture, and thereafter, we have a strict hydration protocol to make sure their fluid intake is good and that they are not behind on their fluids. For those patients or volunteers that need unfractionated heparins, like fraxipyrin, it's possible, but it shouldn't be given within the 6 hours before the insertion of a needle or catheter, and certainly also not before withdrawal of the catheter. It depends on your protocol, but I think ours is it must be 12 hours before the initial puncture and 6 hours before withdrawal of the catheter. All right, now, inserting the catheter, it needs to be done by an experienced anesthesiologist. This has got to be someone that knows what they're doing, someone that does it regularly and has a good pair of hands. We do it with strict surgical aseptic conditions. We have a room that's specially kitted out to the surgical standards with flooring and basin and taps and everything. Okay, so it's a separate room, and we need experienced support. So people there that know exactly what is needed, how to position the patient, and how to help. Now, there's two possibilities. The volunteer could be in the lying position, so we call it lateral decubitus on the side, and very importantly, curled up in a fetal position, or in a sitting position. But that's our preference here, sitting, because with some good explanation, the volunteer can be positioned in such a way that it optimally opens the gaps between the vertebral spines, they're called, and makes it easier to perform the puncture. So we do have a video to show you some more of how this works, but this is just some pictures here. Mentioned before, of course, we do it below the level, below the tip of the spinal cord, usually at lumbar vertebra, intervertebral space 3-4. Once it's all done, we use the volunteers get offered coffee. It's available if they want, and especially if they get headache. And we allow them to mobilize as they wish. So they can mobilize to eat meals, they can walk around, they can go to the toilet or whatever as needed. Now, I've mentioned we insert this catheter. We actually use a catheter through needle technique. And of course, the catheter has to be, when it's in place and we remove the needle, catheter stays behind. Usually you put a few centimeters into the intracerebral space, and then the catheter gets attached very securely to the back and taped up the back with a little reservoir here. So sampling, we do interval sampling over 30 to 36 hours, usually roughly one sample an hour. Also, the sampling is done under strict aseptic conditions. The last thing you would want to do is to allow bacteria to gain entry into the cerebrospinal fluid, into the central nervous system. Typically, we take a total of 20 to 25 samples, in total 50 milliliters, but this is over the 30 to 36 hours. If we do a single puncture without a catheter, we sometimes take up to 20 milliliters in one go, and we very, very seldom have problems with that. So that's the end of my bit. I hand you back to Isaac, and I think he's going to show you a film.
Yeah. Okay, we can do the film now. It should be running now. Yes. You can see the movie right now, and we can make some comments about it. We only see it on the right, but that's okay. We know. This is the preparation for the CSF sampling. Sterile kit. Patient is getting into position. Everything is, as you can see, like an OR. Everyone is washed his hand and has clothing, etc. And here you see the swapping with disinfective. There's a foil, clean foil over it. Everything is
sterile dress.
Sterile, yeah. In the meantime, do you know what gauge we did? The needle, was it 21? 21 gauge?
I think it's an 18.
It's an 18, okay. It's an 18.
Yeah. We use an epidural.
It's an epidural from Brown.
Yeah.
Because our anesthesiologists have a lot of experience with that in the OR as well. You can see that he's pushing in the needle, and then fluid comes out. He knows he's in the CSF compartment. That will drip out, and he will bring in the catheter very slowly. He's doing that right now. And when he has performed that, it all will be fixed. Yeah, again, the metal thread is coming out right now. Okay, there's a bandage on it, and the catheter, where it's catheterized, where it's catheterized when the CSF is taken. Here you see good scrubbing of the guy who's doing, and that's our research physician, who is taking out the sample. So as I said, the place where it is taken is fixed on the shoulder for easy maintenance. And every time we take a sample, after a half hour or an hour, we have to do the whole aseptic procedure again, where we where we wash and do on surgical clothing and gloves, etc. So it's quite an elaborate procedure. So it's taken out by suction of a syringe, and then it's getting back, and the patient can walk away. So I'll go to the next slide. So what is the experience of QPS with this CSF sampling? We have performed around 15 studies in which CSF was collected by lumbar puncture, and all 15 studies were performed in subjects over 45 years. 1 to 7 LPs per subject. 2 involved intrathecal injections of antisense medication, which has been studies performed recently because antisense technology is getting more and more interest in AD and Huntington patients. And 5 studies in continuous CSF with sampling periods up to 36 hours. So 9 studies were conducted in healthy volunteers, in total 90 subjects, and 6 studies with LP were performed in patients with Alzheimer, Parkinson, and Huntington disease, which is a total of 29 studies and 29 patients. 4 studies, 1 LP and 3 continuous CSF were conducted for PK reasons only. All other studies for PK and PD, and most of it were in Alzheimer, where amyloid fragments were measured in tau. There were no dropouts or longer hospitalization periods because of procedure-related adverse events. And the most important adverse events were predominantly back pain and headache, but they were mild. Typically, post-dural puncture headache was rare. It happened a couple of times, but was resolved with simple analgesics and hydration. Now, before we started with this whole procedure, we had a long discussion with the ethical committee, and they asked us to perform a phase 0 study, a validation study, in 7 healthy male volunteers older than 55 years. And the goal was to establish a standardized research tool for future drug development with the primary outcomes of feasibility and the safety. But most importantly, the EC wanted to know what the burden is for the healthy volunteers after and during serial CSF sampling within a zero environment. And the reason for doing that is we were the first CRO in the Netherlands who performed it. Secondly, outcomes. We wanted to see if we could evaluate CSF AD biomarkers, and we went for acetylcholine, which is a somewhat difficult analyte because it degrades pretty fast. The study was performed in collaboration with the anesthesiology department of the University Medical Center in Groningen, and the catheterization was performed by Professor Absalom, sitting next to me, and CSF sampling was performed by our trained QPS physicians and staff in a team. I'm going through this study, which was published in 2012. The average age was 63.3 years old. We had a normal BMI of 24, with a length of 181 centimeters and around under 80 kilograms. 8 subjects were included in the study, and 7 completed the study. 1 subject did not complete because he was getting anxious, and the sampling was not going very well, so he dropped out. Complete study reported AEs were only 6, which is list of related AEs in the table next to the first table, with nausea, headache, lightheadedness, sensation of pressure behind the eyes, dizziness, muscle pain, neck pain and back pain. I come back to that. Catheter side pain, back discomfort and tenderness of the catheter insertion site. All AEs were reported were a total of 25, related were 13, possibly related 9, and very likely related 4. Now, if you look at the VES scales, we did on several occasions. You see over here, and you have to realize, of course, that the VES scale goes from 0 to 100, and with standard error, we never got over 25, so it was experienced as very mild. And you can see that there was hardly any headache and a bit of back pain, which is actually quite normal at QPS, because we have hospital beds which are have hard mattresses, and so it's normal to have discomfort from back pain. The subject questionnaires, we asked them on several occasions during their stay in the clinic, and the first question was, overall, how would you rate your experience of the insertion of the spinal tube, and how was the discomfort? And they could choose between mild, moderate, severe, and extreme, and none. So maybe the majority, almost all, had no complaints, or the complaints were mild. Overall, how would you rate your experience of pain and discomfort? There again, they considered that mild and hardly any moderate, so that was even better. Now, the question was asked on several occasions, would you do the insertion of the spinal tube again? And 100% said yes, okay. And would you do the whole procedure again? Was 100% as well. So it might say something about the mentality of the Dutch volunteer, but it also was experienced as no problem at all. So the overall conclusion over here is that we can say that CSF sampling by either single or multiple shot of LP or serial via catheter is safe and well tolerated, and that CSF sampling, and especially serial or continuous CSF sampling, is a valuable tool for exploring PD and certainly PK characteristics of mainly CNS compounds. And these obtained results will facilitate the next steps decisions in the clinical development of a compound of interest, especially in the CNS area. And that was it. Thank you very much.
Thank you very much, everyone, for this presentation. To open up the floor for questions, as I mentioned earlier, you can send in any questions via the Q&A widget at the top right corner of your screen, just by typing them in the box and clicking submit. Please know that if your question doesn't get answered today, it will be available to be answered at a later date via email. It looks like we've got quite a few questions already. So to start, the first question for today is, do you use ultrasound guidance for LP and or spinal catheter insertion?
Tony.
Right. The short question is no, we don't. And I guess the next question that you might want to ask is, why don't we? In some countries, almost a growing number of invasive procedures performed by anesthesiologists are done with ultrasound, but we don't use it. Our colleagues and myself, we use ultrasound for other procedures like nerve blocks and so on, but not for spinal punctures. Firstly, we don't have any experience in that. Secondly, we don't see convincing evidence that it improves the success rate and we think our success rates are quite good anyway. So far, we've not done it.
Thank you so much. Another question that we have is, do you think it is ethically acceptable to place a spinal catheter for a cCSF in a young healthy adult?
Well, that's an interesting one because, as you know or don't know, PDPH is more likely to happen in the younger population, and it has been described in the literature that up to 65% in people younger than, let's say, 40 can have PDPH, and that is quite a high percentage, I would say. And in our studies at QPS, we never performed actually CSF catheter resection under 50. I think that is probably a very good age limit where you would not like to go under. Don't you agree, Pierre?
Yeah, it's a very difficult question to answer black-white, but certainly the younger the subjects, the more likely they are, and if they're very young, they're very, very likely to get a headache. All studies are with risk, and it's in many ways an ethical question. Would you, if you explain everything and the volunteer accepts the risks and takes their money, is this acceptable? Personally, I would feel uncomfortable in doing it in young patients, even if they accepted all the risks and wants to go ahead. So we've stuck with the older age groups. Maybe I could just answer the question of Pierre Peters, who's saying, why can the elderly tolerate this much better than young ones?
Yeah.
Is that all right? If I, yeah?
Go ahead.
Yes.
I think, yeah. So it's not entirely clear to me why the elderly tolerate it better, but I think it's maybe, it must have something to do with factors. The one is that older people have more atrophy of their brains. It starts at about 45 usually and gets worse and worse with time. So we're at risk, Isaac. But as to replace that space of the brain, there's more cerebrospinal fluid. So they have more, they can use more, and possibly the brain stays floating better. Maybe the dura is thicker or more fibrosed in old people, and when you pull out the catheter or the needle, it closes again. Maybe you wouldn't normally say an older person heals better, but there's a lot of fibers in these in the dura, so maybe they close again. I don't really know the answer. It's not clear, but they certainly can tolerate it much better.
It has been said in the literature that the pressure in older people is much lower than the younger people, which means that you can get faster leakage than in older people. That's the thing which is discussed as well. But it's a lot of assumption there. There's no really hard proof here.
Yeah. But that's certainly true. Generally, in older people, the pressure is a little lower, and that would mean then that they have less leak.
Yeah, that's it.
Yeah.
Okay.
Thank you very much. To continue with another question from the audience, when do you do a blood patch?
When do you do? We already said that.
Yeah, but so basically, if there's severe headache, it's not resolving, and it's been there for a few days, and then that's the situation where we would go for it. And there was a question further down about how we do it. Perhaps I just answer that too. I've explained roughly how we do it, but essentially the question is, we do these punctures, we do these catheter insertions in the QPS facility, and if someone needs a blood patch, it's a specialized procedure with risks and needs really sterile conditions, and patients need keeping an eye on. So then we transfer those patients, we have them admitted to the hospital under the neurology department, and so that they can have the blood patch done in an operating theatre area and get monitored very closely by medical staff of the hospital. So we do it like that.
Thank you very much. Another question we have is, why have you opted for a catheter through needle technique?
Yeah. So if you look carefully in the video, which is on YouTube, I understand, you'll see that we use there catheter over needle technique. So this is a very, very fine catheter and an even finer needle because the catheter is over the needle. So the needle is attached to a long wire, and when the catheter is in place, you pull it out. We did that in the phase 0 study, but we've not used it since. So there's a few reasons. The first is that that catheter is very, very fine. And aspiration can be more difficult, I think, for the cerebrospinal fluid. It's very, very tricky to position. And when you pull the wire out, which also pulls the needle out, it can just pull the catheter back a bit and can cause it to displace. But much more importantly, we have found it difficult to get hold of catheter over needles systems. So there's that. And then finally, these days, the epidural catheters or spinal catheters are placed by our colleagues from the chronic pain team. And we ask them to do it because they do a lot of these in their normal pain clinic. They administer various drugs into the subarachnoid space for treating their patients with chronic pain syndromes. And they use a different catheter and a different technique. So they use what's called a catheter through needle. They use they don't use the biggest needle. They use an 18 gauge epidural needle, use it to find the epidural space, puncture the dura and the arachnoid membranes, and pass the catheter through there. So it makes a bigger hole. Theoretically, it can increase the risk of posterior puncture headache because the needle is bigger. But our experience has been very good. So despite this, we've had very, very few problems with posterior puncture headache or headache on removal of the catheter. And from what I understand as well, maybe they've had fewer problems also with aspirating the cerebrospinal fluid from this catheter, which is perhaps a little more rigid as well.
Yes, in our first study, which I showed, we used a spinal catheter from Brown.
Yeah.
And I think it was 21 or 23.
Yeah.
And we had no good experience with the 23, but the 21 worked. But this catheter went out of the catalog, so we couldn't order it anymore. And then we went to the other one. Yeah. That worked pretty well. Yeah. That's a Brown catheter as well.
Yeah.
Thank you very much. Another question we have is, why do you not require volunteers to lie supine for 4 up to 6 hours after a puncture?
So long ago, this was standard after any lumbar puncture. It was like absolute rigid law almost, yeah, that subjects had to lie flat. And in fact, this is how I was trained, and even after a puncture for a spinal anesthetic, they had to be flat for several hours. And it's been shown that it doesn't help. So the idea was that you could reduce the risk of posterior puncture headache by this. It's been shown that it doesn't help. And so we just allow the people to mobilize as they wish. And our experience is good. And I think a lot of centers have moved to this as well.
Yeah. And that's only recently, because our first study again was done with 24 hours of horizontal bed rest. Yeah. But then these papers came out that it didn't really matter. Yeah. So they now can move after the procedure at will.
Thank you very much. And the last question that we'll cover in today's session is, what is the policy in the event of a blockage of the catheter?
Well, the policy is, yeah, the policy is when it's blocked. You can't get a sample for some reason. You try in the next time schedule to try it again if it's still not running. And sometimes it starts running again, so it's not always that it blocks and then it blocks for the whole period. Sometimes it starts running again, and the volume of running is not always the same. Sometimes it goes extremely slowly, and the next sample is going very quick. But in the end of the day, if there's not possible anymore, and we see it a couple of times, then we stop the experimental part for this patient, and the catheter is removed, and this subject is not included anymore. Is excluded, can go home after the resting period.
I mean, you will understand we can't flush it with anything, because then you're injecting into the cerebrospinal fluid, and you might send if there's a little cloth or something in the catheter, you then put that in a place where you don't want it to be. So we don't flush these catheters.
Thank you very much for answering all those questions. Again, just a reminder for the audience that your questions will be available to be answered on demand as well. So that just leaves me to thank Dr. Isaac Dandas and Professor Anthony Absalom for this great presentation, and to thank UPS for sponsoring this session. To the attendees, you will receive an email telling you how you can access the on-demand version of this webinar, or you can access this through our website. Please look for the email tomorrow. We look forward to sharing further webinars with you, so please do keep an eye on the website, as well as on our Twitter @BRWebinars for daily updates. You can also join our LinkedIn group, Business Review Webinars. Thank you all once again, and I hope that you have a great day.